Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Ladies and gentlemen, thank you for joining us this evening for VITALS, an engaging and open format to discuss healthcare's biggest problems, using the tools of VITALS: value, innovation, technology, advocacy, leadership, and service to help solve our big problems in healthcare and to learn from leaders who are actively doing this. Tonight, I'm pleased to introduce an incredible leader in healthcare in the state of Ohio, Dr. Hal Paz. Hal is the Executive Vice President and the Chancellor of Health Affairs at The Ohio State University, and he is the Chief Executive Officer of the Ohio State Wexner Medical Center. Please join me in welcoming Dr. Paz.
Well, thanks so much for the opportunity to join all of you this evening. It's truly a pleasure and a privilege. I'm so grateful for this opportunity. Maybe I'll just say a couple of words about the Ohio State University Wexner Medical Center and our responsibility to serve. The Ohio State University Wexner Medical Center is one of the most comprehensive health science campuses in the country. It includes our College of Medicine and the School of Health-Related Sciences within it, as well as the Office of Health Sciences, and a number of other clinical operations, including our OSU faculty group practice, the Ohio State University Comprehensive Cancer Center, of course, the James Cancer Hospital and our Solo Research Institute, as well as the entire Ohio State health system, which is made up of 6 hospitals here in Columbus, Ohio. We're the third and one of the most diverse third largest and one of the most diverse academic health centers in the country. And we have a commitment and a responsibility to the communities we serve. And it's imperative that we empower our clinicians, faculty, students, and staff to address social issues that are important determinants in overall health and well-being. Without a doubt, we're differentiated by our 4-part mission of innovative research, education, patient care, and service to the community. And that means that our faculty, our staff, trainees are focused on accelerating the pace of discovery to quickly translate research findings into treatments and prevention, and taking these findings into our communities, particularly those communities that are most impacted by social determinants of health, to make the most important and critical impact. Ohio State Wexner Medical Center has the resources and the capabilities to provide not just healthcare, but a broad base of solutions to combat social determinants of health that are interwoven into these healthcare solutions. With that, I'm extraordinarily thankful to the opportunity that you've given me to discuss how we are using innovation and technology at Ohio State to transform our health system into a health platform that provides a foundation for forward-looking interprofessional education and that addresses all determinants of health and creates value through personalized health, beginning in the home and in the local community. We know that as important as healthcare is per se, at best it attributes to about 20% of health and well-being and impacts premature death. And that the balance is made up of a combination of factors, 4 other determinants: genetics, which probably is about 7 to 10% of our overall health status; environmental determinants of health, which clearly is becoming a greater and greater factor across the country from all the evidence that we've seen, and then behavioral determinants of health and social determinants of health. And when we talk about behavioral determinants of health, we're talking about important things such as addiction to tobacco, alcohol, and drugs. And of course, exercise, obesity, nutrition, and safety factors that we all determine through our behaviors. And then the social determinants of health, the things that fortunately are getting more and more attention over the past several years. Social determinants of health include education, socioeconomic status, housing, transportation, food insecurity, and most recently, we've defined racism as a social determinant of health. There's ample evidence to show that those that experience racism have increased oxidative stress. There's evidence in the literature that demonstrates factors such as poor wound healing, cardiovascular disease. And I think the lessons that we've seen over the past year underscore the impact that this has as one of these important social determinants of health on the overall well-being of those that we care for and those that we serve. And we would estimate that approximately 40% of our overall health and well-being and the impact on premature death attributes to about 40% of this through social determinants of health. We know that in Ohio, Black infants die at nearly 3 times the rate of white infants, and that Black children are 10 times more likely to die of asthma than white children. Black people are 60% more likely to be diagnosed with diabetes and 50% more likely to have a stroke and 40% more likely to have high blood pressure. Life expectancy and health outcomes should not depend on your zip code or skin color, but they do. Black people experience inequity as it relates to their health here in Columbus and across the country based on place. A recent Ohio State study showed that the gap is widening for health and wealth in our neighborhoods, sometimes just blocks away. Here around Columbus in central Ohio, life expectancy in Bexley, which is predominantly white and affluent, is 85.4 years. And just 1 mile away in the Near East Side neighborhood, Columbus neighborhood, which is predominantly African American, the life expectancy is only 67.1 years. That's an 18.3-year gap with just 1 mile of distance between Bexley and the Near East Side. Unfortunately, the COVID-19 global outbreak is magnifying and exacerbating these inequities. Black Americans are impacted by COVID-19 at a shockingly disproportionate rate and nearly 2.5 times likely to die of COVID-19 as white Americans. And that's for the entire population. When you exclude the elderly, the differences for those in middle age is even more significant. In terms of housing, Black families are twice as likely to live in densely populated housing and twice as likely to live with 3 or more generations as white families. And in terms of education, 40% of Black children received no instruction during the COVID-19 outbreak when there were school shutdowns, compared to 10% of white children. All these factors come together, and they've really created for us an urgency for our medical community and the Ohio State Wexner Medical Center to increase our efforts to combat these social determinants of health. So what do these challenges look like, and what are we doing about it? Let's start with a purpose-built communities report last year that called out poverty and place and noted that intergenerational urban poverty is intrinsically, the report says, linked to place and more precisely to neighborhoods. In addition, the report said, quote, urban neighborhoods contain sources of toxic stress for the reasons I mentioned before. And we see in Columbus examples of this. So the roots of the cause of these intergenerational urban poverty, the exposure of children to this kind of toxic stress can be eliminated by transforming distressed neighborhoods into healthy ones. And at the Ohio State Wexner Medical Center, we're working to do just that. And I believe that our innovative location and our neighborhood-based initiatives can serve as a model for how academic health centers across the world can influence and invest in improving physical environments in the neighborhoods that need it the most. Since 2010, we've invested $10 million into Partners Achieving Community Transformation, or PAC, to address socioeconomic factors that influence health in the Near East Side neighborhood of Columbus. The PAC group is collaborating, among others, at Ohio State, the City of Columbus, the Columbus Metropolitan Housing Authority, and Near East Side stakeholders dedicated to creating healthy, sustainable communities in this vulnerable neighborhood. Our Total Health and Wellness Federally Qualified Health Center, along with an intergenerational center and a new Healthy Communities Center now being built in the Near East Side, offer affordable, free, high-quality health and social services to the uninsured and underinsured populations in this area. This center offers wraparound services and provides connections to behavioral health, which is extraordinarily important care, as well as food, medications, and other resources. We've developed a community care and proactive outreach model to address COVID-19 by addressing and determining who is most vulnerable to coronavirus complications and what screening questions would help us identify and provide the most helpful resources to those patients. Early in the pandemic, we delivered community-based COVID-19 testing in vulnerable communities with our mobile community care coach and by creating pop-up testing sites. We also distributed 9,100 COVID-19 community care kits in these zip codes, which included 46,000 masks, over 10,000 units of soap, 18,000 vials of hand sanitizer, and an array of educational material. It's by reaching directly into the communities that we're able to begin to address these very significant social issues. We have moved forward with our COVID-19 vaccine initiatives as well. And to date, we've vaccinated over 120,000 individuals across the greater Central Ohio Columbus region. But specifically, we opened up a second vaccine site in the Near East Side next to our Ohio State East Hospital. And from the beginning, we designated this facility to be available only to those who live and work in targeted underserved zip codes, as designated by the Columbus Public Health Director. This community-based vaccine station currently provides almost 300 vaccines a day. And within the targeted zip codes, we can also address opportunities for vaccinations at our main center, which we're operating out of the Schottenstein Center, where we're currently administering more than 3,000 vaccines a day as well. But importantly, as we address vaccine hesitancy, we're working directly with community organizations, including social service agencies, free clinics, churches, and community centers. And we call them community vaccine partners to make it easy for them to schedule neighborhood residents that they serve. For example, we hold open slots on a specific day for each community vaccination partner to provide sign-up sheets, and we collect them a few days before and then enter them into our system. Prior to the appointment, our patient navigator calls each individual who has signed up via their community organization and arranges needed transportation or interpreter services for the day of their scheduled vaccination. We also target patients of the Ohio State University East Hospital Emergency Department. This is often a population that does not have primary care physician, and they're approached about receiving the vaccine. They're provided with information about its use and development, and again, scheduled for vaccination to reduce the barriers of vaccine hesitancy. There are other initiatives we have underway to drive care into neighborhoods, into communities, and into the home. Taking these initiatives forward in this way, we believe will have the greatest impact on improving health and well-being, particularly for these underserved communities and underserved populations. For example, we developed Healthy Community Day, an annual program to deliver free health screenings in behavioral health and wraparound services for underserved communities, which is staffed by more than 125 medical center volunteers. And this year, with the pandemic, we didn't let the pandemic cancel this year's program, and instead we transformed it into a drive-through program, delivering over 350 free flu shots, 80 Narcan kits, and several hundred pounds of fresh produce to local residents. Before the pandemic, we delivered care to nearly 600 patients during the previous Healthy Day communities and provided over 2,500 free screenings that resulted in 37 new diagnoses. And we expect these numbers to return post-COVID-19. One of the programs that I'm extraordinarily proud of is our Moms to Be program, which just celebrated its 10th anniversary, bringing research-backed perinatal support to pregnant moms in 8 high-risk Columbus neighborhoods, where infant mortality rates had reached as high as 15.9 per 1,000 live births for non-Hispanic Blacks. That rate in Franklin County has now dropped below 7.0 from a high of 9.6 in 2011. In 2021, Moms to Be will be fully integrated into the medical center's continuum of care so that we're able to more easily provide any medical services these families may need. The Department of Family Medicine and the Mid-Ohio Food Bank have also created what we call the Mid-Ohio Pharmacy, and that's pharmacy with an F, where patients identified by their primary care provider are prescribed access to receive fresh produce for free. We also offer an array of free health programs, including psychological care for underserved community members with chronic mental illness, school-based mentoring programs, operational red box safe needle disposal programs, and opioid reduction initiatives. We're delivering in-home care through nurse visits and end-of-life care. We're also connecting to patients and delivering personalized care more completely through technology. The philosophy in healthcare has always been that the patient comes to you. We want to turn that thinking on its head. We're utilizing technology to better connect with patients, delivering personalized care and more seamless continuums of care to reach our most vulnerable populations. Health systems must bring care to patients in the most innovative ways. For example, we know often patients with chronic disease like diabetes, 3 months after they receive a prescription for their oral hypoglycemic agent, are no longer compliant, are no longer adherent to their meds. But unless a physician has an eye into the home, literally into the medicine cabinet, through a home health worker, a nurse, or a community health worker, they have no idea that the patient's not taking their meds. And instead, the patient returns to the office hyperglycemic, and what happens? A new prescription's written at a higher dose or a different medication, but yet to no avail. The importance of reaching into the home to caring for patients in their own homes is extraordinarily important. One example is we launched an app called Care Companions for a growing number of medical conditions, including heart failure, pregnancy, and COVID-19. This enables patients to record health metrics and view their personalized checklists for medication, exercise, and other tasks. We've also dramatically expanded telehealth services and access to care. Prior to the pandemic, we were really pushing for the adoption of telehealth appointments from both a consumer and a prescriber perspective. But to be honest, it was difficult early on. It was a real transformation. And we were averaging about 50 telehealth visits a month. COVID-19 forced us to transform how we use telehealth, increasing our telehealth appointments to a peak of 2,900 visits per day. We've now completed more than 372,000 telehealth visits since mid-March 2020, and this type of virtual care now represents 25% of all our outpatient visits. This transformation resulted in patient travel distance saving of about 12.2 million miles and savings of about 551,000 gallons of gas, or approximately 1.1 million in fuel costs for Ohio State Wexner Medical Center patients alone. And as of July 2020, missed appointments have dropped by 3%. It's extraordinary to see the impact of technology. It doesn't replace the importance of physical doctor-patient or nurse practitioner visits, but it certainly opens up opportunities to improve access to care whenever we can use it. I mentioned the Moms to Be perinatal and infant program previously, and in that case, telehealth and Zoom has allowed Moms to Be to increase touch points with the population it serves by nearly 25% since 2019, despite the pandemic. And finally, the Behavioral Health Immediate Care Clinic, which traditionally provides services to underinsured and uninsured populations, has been able to increase its access to care using telehealth technology. We have to utilize the current telehealth strategy as a springboard into the future, because we know that patients as consumers of healthcare will expect this. They've been able to receive this type of technology from virtually every other sector of the US economy. They will have the same digital and telehealth expectations for what we do as well. Let me just turn to a couple of minutes on what we are doing in terms of interprofessional health science education. Without a doubt, there is no other place like the Ohio State University in the nation. We have one of the largest health science programs in America with more than 9,000 students representing 7 health science colleges on the same university campus. It includes the College of Medicine, nursing, pharmacy, optometry, dentistry, public health, and veterinary medicine. And one of the important innovations currently underway is advancing interprofessional education through the development of interprofessional curricula and facilities to train future health professionals for the modern world, and to really instill in them the capacity and ability to deliver team-based personalized healthcare. We think this is extraordinarily important, not to educate these students in their college silos, but to think about ways to develop a curriculum and a space using patient simulation and clinical settings to, in fact, teach team-based care to these students before they leave. For example, addressing the changing needs of our diverse communities in obesity, addiction, diabetes, and infectious disease, and of course, mental illness requires care professionals who can connect across multiple specialties, multiple health professions, and to do those understanding the use of comprehensive approaches as well as technology. In addition, creating these interprofessional programs, we believe, will allow our students to learn a common language and common clinical paths to achieving excellent health outcomes for the patients they serve. We have enormous work underway right now on developing this curriculum, as well as developing a brand new interprofessional health science center on our campus. This $155 million project includes 120,000 square feet of renovated space, as well as construction of a new additional 100,000 square feet of space to do this interprofessional educational training. The first phase is scheduled to open in January of 2022, followed by the completion the next year. We're extraordinarily excited about the opportunity to train interprofessionally across all the health professions on our healthcare platform that reaches into local communities and into the home. We truly believe that if we do this exceptionally well, we will have a cohort of graduates from the Ohio State University that are going to be prepared for the way that care will be delivered in the future, as opposed to the way it's been delivered in the past. I'm extraordinarily excited about this vision and the opportunities that lie ahead of us. We've learned exceptionally important lessons during this pandemic, and we're taking those to heart to think about what the future must look like and what our responsibility is to the patients we serve, to our students and other learners, and to those that work across the Ohio State University and the Wexner Medical Center. I'm delighted to have the opportunity to be with you this afternoon, and I look forward to talking further about some of the innovations underway. I hope you will all join us in this important work. Thank you so very much.
Dr. Paz, thank you so much for your presentation. Hi, everybody. I'm Monica Robbins. I'm your question moderator. I encourage all of you to go into the Q&A section on the Zoom and please ask a question. I will be happy to ask Dr. Paz about it. So we have a couple already. Rod wants to know, did the pandemic make you more convinced that healthcare is truly innovative or more concerned that it is not?
So thanks, Monica, for the question. Without a doubt, I wouldn't hesitate for a second. It has convinced me that we have been extraordinarily adaptive at addressing this pandemic. I'll give you a few examples, and these are just a few that are top of mind. So early on in the pandemic, we were able to do about 30 COVID tests a day. And if you all remember, they were in extraordinarily short supply. Literally within a matter of weeks, our faculty and clinical staff at the Wexner Medical Center were grabbing PCR machines from around the university and from VITALS, which is our large research institute across the street from the Med Center, and created a testing platform that took us from doing literally 30 tests a day to having the opportunity to do 4,000 tests a day. That happened in all of about 2 weeks. We quickly started to ramp up testing, and we realized we were running out of swabs to put into patients' noses or throats to actually check for the samples. Why was that? Because most of those swabs were made in northern Italy. And if you remember the early part of the pandemic and those photos from northern Italy, you can understand why they weren't making them anymore. I mean, northern Italy was overwhelmed by the virus. So what did we do? We grabbed 3D machines from the College of Dentistry and the College of Engineering, and we used 3D machines to make our own swabs. And then we had a contract with an auto parts plant in Toledo that wasn't busy because of the extent of the pandemic. So we went into business with them to make swabs. So then we started swabbing. We need to put the swabs into vials, and you need preservative called viral transport media. And guess what? There wasn't any. So we found the recipe for it on the web, and we started making our own viral transport media to actually process all the specimens. Other cities and states were running out, so we started shipping the viral transport media to other cities on weekends to help them out as well. The ability to just respond and turn this around gave us, first of all, enormous opportunities to serve the community. It gave us a sense of the ability to innovate and to do it quickly. But it also taught us important lessons about what we can do when we're not in the middle of a crisis like this, that when we have a vision for what we want to achieve and a vision for the future, there is no reason why we can't be agile and why we can't adapt quickly to use innovation to advance the work that we do. So I think this has been an extraordinary lesson for us, and just an enormous sense of pride across the organization of what was able to be achieved in a very short period of time.
That was definitely something that we all noticed early on, that we had such a reliance on foreign resources for things like PPE. What do you think is going to happen now that we've learned these lessons? What do you expect to see?
Yeah, it's a great question. I've been in this line of work for about 25 years or so as a CEO of some part of the healthcare system. And I remember early on, we used to have warehouses where we would stock all the supplies that we needed for the hospital. And then we got into what was called just-in-time delivery. And we had to build new loading docks because the trucks would come 24/7, these huge trucks, drop off what we needed for that day or the day before we would do a surgery, for example. And that's how things ran. And it was very efficient. You didn't have to stock huge quantities of supplies. But then we learned during the pandemic that that doesn't work under these conditions. So I think we're going to see, going back to, not to the way it was 2 decades ago, but I think we're going to see some kind of a process where we have adequate amount of supply and we have redundancy in the supply chain, so we don't find ourselves in this situation. It's a little bit, the analogy is like keeping your computer on warm. We're going to have that warm setting for the supply chain, and make sure that if there's ever a major disruption, and disruptions can be all kinds of things. They can be pandemics. They could be very big ships getting stuck in canals, as we've seen. Anything is possible. We have a responsibility, particularly here, where we're a trauma center, a burn center, a quaternary care center. We have to always make sure that we're ready to go. And again, I just can't say how proud I am of how everybody responded so that we could be a national leader. And that was really a great accomplishment.
Elaine's question sort of touches on your social determinants of health. She wants to know if you can talk about the logistics involved for a physician to write a prescription for healthy food. How much coordination of resources by community organizations like farmers markets is involved to make this possible? And what would you tell a physician who wanted to write a prescription like this? For example, can you refer them to an organization who serves as a hub?
Yeah, so we're exceptionally fortunate to have outstanding programs here at Ohio State in dietetics and nutrition through our College of Agriculture. And this is, again, really a team-based approach where we can work collaboratively to make sure that where we see deficits in terms of nutrition, we can work directly. And again, we've worked very closely with the Mid-Ohio Food Bank, the Mid-Ohio Food Collaborative, to address these opportunities. It's recognizing that food insecurity is a huge social determinant of health, and that if we're going to address, if we're going to have an impact on addressing it, particularly with regard to chronic diseases like diabetes, we have to have the healthcare team, beginning with the physician, directly engaged in understanding what the patient's diet situation is and then how we can impact it. So that's the whole idea of why we call it a pharmacy, F-A-R-M, as opposed to P-H, because we think that that underscores that this is not something that is just a choice, but is something that is essential to well-being.
Stephen wants to know, he says, Wexner Center is clearly leading transformational changes in healthcare in Columbus and throughout central Ohio. Can you talk about the type of leadership required to design and deliver these programs? And how do you recommend health profession students develop as leaders?
So that's a great question. I think that, as an academic institution, we have an enormous responsibility to develop and train our workforce and to really build pipelines for succession planning across the organization, and to have this willingness to be innovative and adopt great ideas and to look even beyond our borders, the healthcare sector, to look at other sectors of the U.S. economy and to learn from them. And I think that's extraordinarily important. And that can happen in a lot of different ways. First and foremost, to be evidence-based and to look broadly at the evidence. The evidence may not just come from the medical literature or the health science literature, but comes from other places. To be heavily engaged in technology, because we realize that technology can be extraordinarily important to help us advance our programs. If you visit our webpage right now and you want to interact around our vaccine program, you can interact with the AI programs we've developed through our bots to get the answers to the questions that you need. We're doing a lot of innovative work with Epic, which is providing our EHR, and we've used that as the way that we register every patient that needs to get a COVID vaccine, our own patients or patients from the community. And the technology is so advanced that we can load 2,000 patients into our vaccine center in 2 hours. So it's really about beginning first and foremost with understanding the data. And we put a lot of emphasis on data and analytics. After I arrived here around 2 years ago, we created this analytics center, which pulled together all the analytics from across the Wexner Medical Center and its component parts. So in one place, we have the opportunity to take a lot of this data, understand its significance, to try to do predictive analytics, and then see where we have the greatest opportunities to align our workforce with what those opportunities are and to continue to provide them data on everything from performance, their own performance, to outcomes. So that's the kind of feedback loops that are really important to everyone to have an understanding of how we're doing as an organization. We have frequent surveys. We try not to over bombard with surveys, but doing surveys is an important way of understanding our own workforce and their health and well-being. We all know that in healthcare, burnout is a very significant issue. What are the things that we can do to address that, particularly during this pandemic, where it was only exacerbated and amplified? And then thinking about ways that we can reduce those burdens to allow individuals that work here and teach here to be as productive as they can be. It's an important part of what we've done, particularly during the pandemic, but that's an ongoing set of initiatives that we have underway. We think it's just as important to talk about what we're going to do to improve the health of the communities we serve. We also need to talk about what we're going to do to improve the health and well-being of those that work here. And then last but not least, I would say, making sure that we expose everyone here to new ideas and to try to be as open as we can to bringing them in and making good cases for when we should take those and amplify them and integrate them into our work. It's really 3 phases. The first phase is developing what our vision is, and our vision, which I said at the outset, is to transform a health system to a health platform and to lay on that interprofessional health science education so that they're totally intertwined. And we believe that starts through focusing on the individual personalized health beginning in the home and the local community. To establish that vision and develop a strategic plan that has the appropriate touch points in it identifying the individuals responsible for each aspect of it, having direct metrics for what we're going to achieve in a year, having identified financial measures for the investment in each of those areas, and then to hold ourselves accountable for its achievement through our annual review process. It's an important part of how we do our work.
How do we get more women and more diverse candidates into healthcare leadership roles?
Yeah, that's a very important question. First, let me just say I'm enormously proud that last year, in 2020, Forbes published its most diverse corporations in the country. They listed typical for-profit corporations you would think of, but also health systems. And I'm enormously proud of the fact that the Wexner Medical Center was ranked 4th in the United States after Procter & Gamble, the computer company SAP. We were 4th in terms of having the most diverse workforce. And I think that speaks volumes about the attitudes that we have here about the importance of diversity. We've worked very hard to ensure that as we do searches for leadership roles, that we start with having a diverse search committee. Having diversity on the search committee is the first step to making sure that we have a diverse roster of candidates to meet with. We do implicit bias training before we start that search, because that is an important undertaking to make sure that everyone that sits on that search committee thinks about the candidates they're meeting with the most open mind possible. And we strive and we emphasize the need to recruit diverse individuals into the various roles. We always feel that there is more and more work we can do. We're enormously proud that just this week in US News and World Report, among the top colleges of medicine, we were ranked 7th in terms on the diversity scale. We're exceptionally proud of the fact that overall we're ranked among the 4 top medical schools in the nation, when you exclude the 4 historically Black African-American medical schools, in terms of diversity. We've doubled the percent of underrepresented medical students in the past decade. That doesn't happen by accident. That happens because of a purposeful decision to emphasize diversity. And we've done so with outstanding students coming into this, and as evidenced by the most recent match, outstanding performance by those students when they leave here. It's an important part of what we do, and we've really included that in our thinking and in our culture. And we think it's exceptionally valuable if we're going to have conversations about how we serve underserved communities, because it means a lot to those that we care for when they see that we really emphasize this and are doing everything we can to advance it.
Of the 10 to 20% of controllable outcomes, where are the pitfalls in each of the following areas? Medical education, healthcare practice, hospitals, and like providers. And what does each need to do to bring positive change to systemic racism that does exist in healthcare?
That's a long question. You're going to have to read that one to me again. Let me think through that a little bit.
All right, we'll take the first part.
Okay.
Of the 10 to 20% of controllable outcomes, where are the pitfalls in each of the following areas? We'll start with medical education.
In pitfalls in terms of what, Monica? I'm sorry. That's the part I was trying to connect back to.
It doesn't, it's not referring to any specifics, but it just says, where are the pitfalls in each of the following areas? Medical education, healthcare practice, hospitals, and like providers. I think it's referring to systemic racism. So
okay.
what do we need to do to combat that particular issue in each of those areas?
So give me the first area again. I think I'm getting
medical education.
Yeah. So I think it's incredibly important to have diversity among the classes. You know, I truly believe that students learn as much from each other as they do from the faculty. And if we're going to have students in small groups, and now here, as we've emphasized, interprofessional education, small groups among multiple professions in the health sciences, having diversity of the student body, particularly underrepresented minority students, is incredibly important. The experiences that I had as an individual before I became a student is what I bring with me to that setting. and all of us can learn from each other as we interact around the work that we're doing as learners. Same thing for the faculty and staff. It's incredibly important to have that diversity, and that's why, as I said earlier, I'm so proud of the progress that we've made here. But then, of course, in the clinical setting, and I'm thinking now about our clinically trained students, to be able to make sure that we have set up clinical sites that really address the issues that are so important to this question, and that like the work we've done on the Near East Side at Ohio State East Hospital in the Near East Side community, which is largely an African-American and underserved community historically, to have those programs. We just spent, for example, $27 million making major renovations to the East Side Hospital. Why? Because we are passionate about the fact that anyone that visits any of our facilities should see the same kind of facilities no matter where they go and where they come from. State of the art, clean, beautiful, and not something that in the old days we used to call clinics with folding chairs, and something that looked like it was not at the same level as the marble halled facilities that some of us have walked through. These are all, and some of them tend to be almost intangible, but they send strong messages. Our success in delivering care, be it adherence to medication or vaccine hesitancy or mask hesitancy, are all trust-based. Being able to develop a trust-based relationship with a community or with a patient is the best way that we can all be successful as clinicians. And if we can't achieve that trust, it hinders our ability to do the things that we spent so many years training to be able to do.
I think you touched on those other issues, but still relating to systemic racism, the other, I'm going to lump all of them together: healthcare practice, hospitals, and like providers. What are the pitfalls and how do we fix them?
So again, it's an ongoing process. We've just launched an initiative in health equity, including an initiative at the Wexner Medical Center called our Anti-Racism Action Plan. We've put a lot of work into this because we think it's important to first and foremost share with the public what our action plan is, what do we seek to achieve, and then be able to report out in a very transparent fashion what we're achieving. I gave you some examples earlier during my remarks of some of these initiatives that we have underway. But within the context of the Anti-Racism Action Plan, we're talking about programs that are underway, number one. Number two, the investments that we're making in these programs. And then being held accountable by the community to our success in achieving them. We think that's extraordinarily important. And the Anti-Racism Action Plan pulls together different parts of the Wexner Medical Center to move these initiatives forward, to really address what you were asking me in the question.
Allison would like to know, what are the personal characteristics you believe are most important to being an effective leader?
Great question. I think first and foremost, it's the ability to listen and to take the time to listen and to communicate frequently. I can tell you, I arrived here, as I said, just under 2 years ago, and very purposefully, I made sure I spent very little time here in my office, which is where I am right now, and spent most of my time out and about the medical center, the colleges, the community, meeting with community leaders, meeting with people that live in the communities, and spending lots of time with our faculty, our staff, and our learners. Why do that? Well, first of all, so much of what we can do to be successful leaders depends on us showing up. Second of all, you have to have a deep understanding of what are the issues, what are the challenges, what are the points of pride. And that assessment early on is so vitally important. You know, after a while, if you don't do that in the beginning, after a while, the cement dries a bit and you don't get a second chance. So I would urge anyone that's taking on a new leadership role to take advantage of that. And I know there's a real, sense of urgency to get to the work. Trust me, the work, the work will always be there, but the opportunity to introduce yourself and to learn about those that you serve as a leader is really there once. You have that first opportunity to make that impression, and you have that opportunity for everyone to make that impression on you. So that's number one. Number two, you can't over communicate. You just can't over communicate. A lesson I learned from one of my mentors along the way is you have to keep on repeating the same message over so many times that when you think you're done, realize that you're only halfway there. And find many different ways to communicate. When I got here, we put together a social media team because I know many of our folks are communicating over social media. Put together another communication team to do that by email, and another to do it on our webpage, and another to do it in writing. And now we're using more and more video, like I'm sure many of you are using, to communicate. And to be flexible, get out of your comfort zone. Maybe TikTok is the way you're going to communicate. I don't know, but think about who your audience is and think about how you can best get to them. Some of my colleagues are using Instagram as a way to communicate. Don't worry about what you've done in the past. Worry about who you want to work with and how you can be effective. And then number three, think about what your areas of responsibility are and fight your tendencies to be a micromanager. Early in my career, I ran a medical intensive care unit, and I did that for a number of years. And I'm pretty sure they were paying me to be a micromanager. Patients' lives depended on me obsessing over every little detail. These folks, as you all know, critically ill. But after I, would get new leadership opportunities over the years, I quickly learned the worst thing I could do was to be a micromanager. And the best thing I could do would be to go out and recruit and retain the best and brightest teams that I could, to make sure that we're all aligned against the same strategic plan, that we developed a really excellent relationship based on trust and communication, and that I trust them to do their jobs. And that, much like a coach or an orchestra conductor, if everyone is working together effectively against those goals, we can all achieve much, much more than one person trying to dive deep into every single issue. Now, don't get me wrong, there were certainly times when I had to kind of stop what I was doing, think about what wasn't making sense, and dive deep into it. But that had to be infrequent and had to be the exception, not the rule. And when you have a well-organized team that's functioning together like a team, you can't help but be successful.
I really hope TikTok is not the future of our communication, but
I was just an example. That was not a commentary.
That's just me. You gave some great examples about how the medical center is trying to close the gaps regarding the social determinants of health. But one thing I may have missed or I didn't hear was bridging the digital divide. What if anything is the Wexner Medical Center doing for those communities in need who maybe don't have access to decent Wi-Fi or computers, iPads, what have you?
Yeah, that's a great question. And here in Columbus, I could pretty much say that broadband is ubiquitous, right? So that's not the challenge. The challenge is the so-called last mile into the home, or the last 50 feet into the home, to be more precise. What's going on there? What are the hardware challenges, but also what are the software challenges? If the elderly are not facile at using the technology, it's not going to do them any good. If they don't have time or the ability to access the technology, even if someone received it, how do we help them? And then certainly there's the issue of cost and income, which for many individuals, particularly in underserved communities, is a huge barrier. So we're doing a number of different things there. So with the elderly, for example, we might not expect them to use telehealth in the sense that we all think about it, but for them, telehealth is telephone health, because we know that 20% or so of the patients that we interact with over video are not able to actually have a video session. That's where I think community health workers going into the home can be very helpful, because we can help those individuals with the technology. Working with local organizations around getting access to devices is also another thing that we think is very, very important here in the geography that we serve. But I think the first step to your question, Monica, is the recognition that just because we have all the technology and we have the pipes and the ability to send it into someone's home doesn't mean that they're going to receive it. And we have to be able to adapt to that, come up with solutions to help each individual one at a time.
Stephen would like to know, in addition to Wexner, other academic health centers throughout Ohio are impacting transformational changes in their respective communities. How can best practices be shared throughout the state to impact all of Ohio's citizens, including those in rural communities?
Yeah, that's a great question. We have many programs that we put on here that we want to make as inclusive as possible. Certainly, early in the pandemic, this was something that came home very quickly. We saw what was happening in cities like New York in the pandemic when the hospitals there were overwhelmed with COVID patients. And we said, could we learn from that and do something about it early on? So we have this ethos here called the Columbus Way. And for the past 20 years or so, there's been this notion that organizations in this city, in the central Ohio geography, have a responsibility to collaborate and work together. That's for-profit corporations and not-for-profits. And it's been part of the culture here in this community. So early on in the pandemic, the 4 health systems, 3 adult health systems, and Nationwide Children's Hospital got together and said, we're not going to wait to see what happens. We're going to get together as quickly as we can and create a response to the COVID pandemic. We went out, we didn't wait for FEMA to show up or the National Guard to show up. We went to the city, we asked if we could take over the convention center, lease it, and we put 1,100 hospital beds in there for a level 3 surge. And we organized among ourselves to do it. But then we went to the other 37 hospitals across central and southeast Ohio, which is zone 2 in the state. And we organized ourselves among them as well to say, look, if you get overwhelmed with admissions of patients with COVID, we can all work together to better level set and distribute care across all of central and southeast Ohio. And we organized that. And again, there were times when we'd be transferring patients from one location to another because they needed ECMO or other resources. But I think it had an extraordinary impact on our ability to deliver care. We never got past surge level 2. We never had to use the convention center. I'm asked frequently, do I feel like we wasted a lot of money? And my answer is no, we didn't waste a lot of money. We were just buying insurance, and all of us buy insurance all the time, and we certainly hope we never have to use it. But I think, and by the way, the meetings of those rural hospitals and the hospitals here in Columbus continue on. I think, again, it's another lesson learned and opportunity from the pandemic. What can we do to better coordinate among ourselves? There are great hospitals in Northeast Ohio and certainly in Southwest Ohio. I think that if we can focus on each of these 3 major academic centers can focus on how they can work collaboratively to coordinate and to make sure that there are opportunities to innovate broadly. I think that creates win-wins across the entire state.
Rod would like to know, with the issue of health professional burnout already occurring and an anticipated shortage of health professionals to be over 100,000 in just the next few years, we seem to be headed for a surge of a different kind, higher demand than supply of care providers. What are we going to do?
It's a great question. It's an important concern. The good news is we've seen an uptick in applications at our 7 health science colleges this year, and we're exceptionally pleased. I'm sure it's multifactorial, But without a doubt, that may be great for us, but it may not be great for somebody else. And we recognize that. I think the first step is really to focus on K through 12 education and to better think through how to coordinate the education and training of students for the health professions. And that can take a number of different courses. In my previous lives, we built a magnet school on the Med Center campus. We developed collaborative programs with a high school, so the students in their fourth year had an opportunity to do practicum experiences at the Med Center to give them the experience and the exposure to the health professions. Not everybody goes to college, so can we convince these students that with an associate degree, they can have a phenomenal, well-paying job? And for others, can we create programs, pipeline programs, where they can go from college to any of the health profession schools to continue on their training? We think that's extraordinarily important as well. But I absolutely agree. We can't take this for granted, that this is not just going to happen on its own. We know that as we have an aging population in this country, we have health practitioners that are retiring at increasing numbers. We just have a huge amount of work just to stay in the same place, let alone plan for the future, a future where it won't be uncommon to be over the age of 100. So, and the last part, and this is why I'm so passionate about this notion of interprofessional education, I truly believe that if we can create more effective interprofessional teams, we can do more with less. We can be more effective together than apart. We know in this country, you know, of the 3.7 or so, $3.8 trillion that we spend on healthcare in America, it's the largest sector of the GDP. Roughly 25 to 30% of it goes to waste. This has been demonstrated in study after study. If we can create a more efficient workforce, a more efficient national health system in this country, we can reclaim about $1 trillion a year. That's more than we spend on all of higher education in this country, and put it to better use by addressing social and behavioral determinants of health, by working in local communities, by better harnessing the opportunities that come with technology to be able to make sure that our workforce can do more, but also experience less stress and less burnout so that their jobs are as fulfilling as they possibly can be.
Stephen has a great question to wrap up this hour. Down the road, when we are able to look back at the pandemic with perspective, what do you think the most significant positive impact the pandemic experience will have upon healthcare?
Boy, one thing, I can give you 20, but I'll tell you one. Before this pandemic, the shortest amount of time it took us to develop a vaccine was 4 years. This time we did it in less than a year. And it was the coming together of research and science, the coming together of the healthcare health system in this country to be able to develop something that has offered patients the opportunity to not become infected with a disease that could land them in the hospital and kill them. You know, I realize that this has been an extraordinarily challenging year. The number of people that have died is just tragic and extraordinary. And, you know, we could argue that there were, you know, if everyone would have worn a mask or whatever, we could have had an impact. And I think it's exceptionally important to understand how important it is to have trust in science and to be able to create a relationship with patients and the public so that the things that we know make a difference are going to be accepted. But at the same time, we also know that we were able to use discovery and science to create a vaccine that we're seeing in real time have just an extraordinary impact on reducing hospitalization, reducing death, and keeping people healthy. And that to me is extraordinary to do it in such a short time. And I think the lesson learned is, and you know, I gave you examples of COVID testing that we set up here in a matter of weeks, or the number of people we vaccinated here, telehealth, that when we put our minds to things and we work together as Americans, there is nothing that can stop us, that we can, not even a global pandemic, and that we can make extraordinary progress in short periods of time. But that all happens because of the investments we've made in research and education and training, and we have to continue to do that if, as a nation, we're going to continue to be the world leader in all of these advances.
Dr. Paz, thank you so much for all of your incredibly valuable insight. I want to wrap up the hour and let everyone know, I hope you join us for the next Vitals. It will be next month on May 6th with Mehul Patel, who is the Associate Chief Medical Officer at IBM. Thank you all. Have a wonderful weekend and stay well, everyone. Take care.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.